Good evening, Namaste, Sat Shri Akal, Adab. Welcome back to the day two of this series of webinars in honor of Patient Safety Awareness Week that happens every March. And Cygnia Healthcare, in association with Nurse India, is proud to bring you webinars. And I'm today very honored to present to you someone that all of you are already aware of. So it goes with a thank you to each one of you present here, and plus our invited speaker today, Dr. Jothi Clara Michael, for being here to talk about one of the most relevant and very important focus to ensure patient safety, because that is the near misses. I'm sure that most of you sitting here, you understand the iceberg effect. The Titanic sunk because of an iceberg, which harm probably happens more because we don't pay attention to what is beneath the iceberg. And today, that is what Dr. Jothi Clara Michael is going to discuss. Hidden iceberg and near misses, the power of, focusing on near misses. I don't have to introduce Dr. Jothi Clara Michael to all of you. Everything is written down there. Only new thing is today she is not sitting here as the group nursing director, but she is sitting here as the founder, Health Bridge, and she already has multiple appointments under her kitty. She is an advisor to Global University Foundation and Global Innovation Hub, Chief Strategic Advisor, BECMED, and board member for elderly and motherly, and of course, she's the founder of Health Bridge. So, Health Bridge is a very apt name. So, that's the bridge I am going to use very frequently to make sure that we stay connected and we do things together that is, beneficial for our nurses and through our nurses for our patients, because that's where uh, all the roads in healthcare should lead to patient safety. And we should prevent all preventable patient harm. So, ladies and gentlemen, it's an honor for me to present Dr. Jothi Clara Michael on this platform, organized by Cygnia Healthcare in association with the Nurse India. So, very warm welcome, Dr. Jyoti, and once again say thank you so much for being here, taking your time, and we have a good number to start with already. Over to you.
Thank you, Ms. Tankam. I am deeply honored to be here. I think this is my first talk after I have resigned as a group head nursing. And I'm very happy today because I'm self employed and I am free to do, as Tankam has said, what we wish to do for nursing. And that's the reason why we are connected. And Nurse India and Cygnia is very close to my heart, and we have always look forward to work together. So today's presentation, first of all, I would like to thank each and every one of you for being here, because your presence is something that's going to be a great motivation for me, especially leaders like Ms. Abanti and the principals, the other healthcare professionals who have joined here. So the topic is the iceberg, the near miss in healthcare. I little bit tweaked it here because my presentation is more specific in healthcare, and this is mostly going to give certain ideas, innovative thoughts, and probably it will also kindle some of your inner feeling and self that is within you, so that you may go back and probably some of you will develop a cell or an initiative or something that will promote near misses catches, and that will promote a better thing. Why do I say that? Because nurses are 24 hours at the bedside. If the nurses are not able to capture near misses, none other professionals will be able to do it. This is my proud statement that I would like to place it here. What did you know about all these? I think most of you know about it. It comes from analysis from different countries, and not only other countries but also India. I have a list of every country giving some statistics. I just picked and chose only three of them to present before you, and that gives a clear idea that near miss events occur in all the countries, in all the hospitals, in every healthcare settings. It's just how much we capture. How much courage do we have to capture it? And how are we taking those into a initiative, in fact a strategic nursing initiative, to promote reducing errors and preventing. Sometimes, when I joined from academia to healthcare in 2009, Ms. Abanti was the first person to came from NABH to assess NABH nursing excellence in our hospital when I was a chief nursing officer at Global Health City. So I still remember the good words that she has shared with me.
Excuse
And
me,
during that time,
excuse me, Jyoti. Can you please start your video? I somehow got the video has gone off.
uh, video has gone out.
Yeah, yeah. Now your presentation is there. You can just
Uh-huh.
start your video.
My video.
Your
My,
picture, your
I I don't know what's happening because it is the same screen. Probably that's what I told. When the screen comes, probably I'm not there. I think I can continue still.
yeah, yeah, yeah. Please.
Yeah. Yeah.
सरस अरे वाह
Okay.
सारू करियो करी करी सारू
Hello, hello. Please mute Ratan. Yes, go ahead.
So, so when you say when there is a error happening, the first thing that I focused as a chief nursing officer when I moved from academia was the near misses. And near misses comes out only when a proper climate is provided for the nurses. A fearless reporting and a blameless information giving is very, very important. Now, when you see here, the statistics very clearly states that near miss happens more than 300 times as often as adverse events. But are we capturing them? Some of the institutions do capture. That's how it has come as a literature. And these literatures are not very far literatures from way beyond, but it is the most recent, like 23 and 24. It has been published in standard organization and by the organization and in a reputed journal. You could see all these coming out. And near miss even should actually, when you see, it is approximately 44% of the total safety reports within the organization. How many of our committees have a report called near miss safety report? We don't. Many of our meetings in the committee do not have such reports. I think this is one takeaway for all of us, to go back to think about, like, how do we capture them and how do we present it in the organization so that the organization gets more benefit and the nursing gets the pride that they are able to bring forth all these informations in front of the professionals, those who are sitting in the committee. And when you see in Singapore, again, it is the same. They say that system reporting, that is electronically, when they introduced the capturing, the near misses reporting increased 30%. While I was working for Kaveri Hospital, because they have their own um, HMS system where it was developed by Dr. Manivannan. I was very proud to work for them for almost 2 years, where I was literally able to see this percentage, what is reflected in the Singapore journal. The increasing capturing happened when we started using an electronic system of capturing. And if you see in India, it is not lesser. But you can see here the incident, they have given it in maternity, maternal and child health, neonatal, those fields have published a lot about it. But still in India, we don't have in other specializations, maybe in super specialization, some of the near misses being captured and published. This is a great opening for the research scholars, those who are attending this session. It will be a good opportunity for you to maybe think about it. Now, Government of India, when you see in 2014, have brought in a document which was released, which gives an operational guidelines for maternal near misses, and that has actually impacted a lot from then today. And we can see that very clearly even in Tamil Nadu. It has happened in many of the maternity health centers. Now, I would like to quote Peter Drucker's statement. The greatest danger in time of turbulence is not the turbulence at all, because we cannot avoid turbulence, but it is to act with yesterday's logic. So, what I would like to request all of you is there is no one particular solution. As you take things forward in your day to day activity, the near misses will unfold lot of strategies, lot of ideas, lot of solutions that you can bring forth to the organization, and that's how we contribute as nurses to the healthcare. Now, when you see this theory which Heinrich's accident theory, it clearly divides the entire segment. So it says that serious injuries happen, that is in red, the one, that is if it is one, then you will have a minor injury of 29 and a near miss of 300 and unseen act behavior. Yesterday, Tankam was covering a topic which is very much related to behavior and attitude. And these behaviors not only are intentional, sometimes it is unintentional as well. So that counts for 3,000. So see the magnitude. For every 3,000 unsafe act and 300 near misses and 29 minor injuries, we end up with one serious injury or death. So we cannot say that it's just one serious event that has happened in an organization, maybe in 6 months, 3 months, and 1 month. But we can always say it is the 29 that we have not captured, or 300 which we have missed it, or 3,000 members whom we have not taken care. So, the cornerstone of 20th century workplace health and safety philosophy is this: we have to identify unsafe act behaviors that actually both intentional and unintentional causes injuries that are preventable. I'm giving these theories for all of you because these are the theories which have been proven right, and they have given some results. So probably one theory would attract you for application in your particular setting. So please feel free to take back. If you have any doubt or any clarification, you can come back to us, to Cygnia and to me and to Tankam. We will be able to help you out to understand these theories further, and also help you to apply them in your setting, so that you will be able to actually go by theory, and you will see how we are able to systematically reduce the errors that are potential errors that are going to happen. Now, this theory talks about incident, accident, unsafe act, fault of person, social environment. So I talk so much about the social environment. When you tell social environment, the environment within which the nurse works, within which the healthcare professional works. So people, the workers, the employees would be fearless if the environment is conducive and if it asks for. These initiatives cannot be from down up. It should be from top down approach. So much the top gives the emphasis and the philosophical opening, the organizational transparency, and they are ready to work with the team when they bring out, then that kind of organizations would propel forward in prevention of injuries. Now, this is another wonderful model. I love this model because this model talks about great things that possibly could happen and that we have to focus. The iceberg model was flipped into a whirlwind model. This whirlwind model is much operational. The model illustrates the key functions, parameters, and compliance efforts that must be coordinated and collaborated in order to deliver a safe patient care. It is just not a single domain personal person, those who are working here. Nursing cannot function alone. We need operations, we need medical professionals, we need every single stakeholders to partner with us. And in fact, this is little broader even for us. The person who supplies our supplies and medicines, the person who is storing it, and even the person who is even removing the waste from from the source or from the institution. So all these are contributing towards this particular concept that says that whirlwind model, operationalizing the iceberg. So this is very interesting model, but it needs little bit understanding. And if you want references, I've given the references. So if you go into the reference of American Data Network's patient safety organization, they give us like how exactly we can use them and we can promote them, because they believe a good process and any system is strong, that would certainly prevent. So while focusing on individuals, we can also focus on the processes and the methods that are involved in the delivery of healthcare, which will help us to make near misses almost very less, and we can even prevent injuries or errors that can reach the patient and do the harm. This is the patient safety. When you talk about, it's very complex. When you say complex, again I'm repeating it, we categorize them into incident, near miss, and unsafe condition. So this again was yesterday discussed, and I am not going to touch much about it. But however, I would like to caution you that there is something called as mental models. That is, you have to have a transformation at that level. Assumptions, beliefs, values. What do people believe? What do people value? So many times we believe that we take things for granted. You're all attending here for this particular session. Probably you're interested to attend to it. But for some, it may not be the priority. For some it could be the priority, but the situations are not right to do, right to participate. But what I would like to emphasize is, don't see, if any incident happens or near miss happens or unsafe condition is seen, go deep diving. That is what under the iceberg. Go beyond that, which is a mental model, and then understand people, because it's the people who are functioning. It's more than the machines. Even the machines are operated by people. So it is important to understand whether every member in the organization, right from induction, right from upskilling, right from periodic nursing, continuous nursing education, and then you list down the never event in the hospital, and you say these are the behaviors expected from everyone. It will not be enough if you put it on the poster, or if you share it with the team, maybe by one to one or in a group, but it should be inscribed into their DNAs. So I call it as a culture. The mental model is focused in any organization, then that creates a culture in an organization, which is can be defined as a patient safety culture. Near miss incidences in healthcare can happen in many areas. So, what do you do in your hospital? Like, you can divide them accordingly. I remember earlier when I was a group head, country director of nursing for IHH group of hospital. I think Jessica and team, some of them are participating here. CNO said that they are going to be logging in to attend to this either as an individual or a group. But what I would like to say is, like, we had something called as best catches, and these best catches are similar to near misses, and these were categorized. Like, we even subdivided into medication related, medication management related, then iatrogenic injury related, HIC or infection control related. So you divide them. Initially you will start with general, and then what you have to do is you should divide. So what happens is, in each bucket you will see how many near misses are being captured in the hospital. So normally you see that most easy one is, you will find the medication error is most commonly identified one as a near miss. But near misses on areas like patient fall, or some other areas, it is very difficult to capture and it doesn't come out. It's not difficult to capture the sin, but difficult to, they are not reporting it. So near misses, in I have just given only four here, but you can classify into maybe 20 to 30 classification, bucket them, and then promote and have a champion on that. So then members will come forward, like for example tissue viability. So tissue viability near misses can prevent pressure injuries, all iatrogenic injuries, burns. So all that can happen. So near misses is one thing that will help us go to zero incident occurring. But however, you can have near misses. As an NABH assessor, I think many of the NABH assessors are also here, and Ms. Abanti will agree with me when I talk about, like, when you present your incidences or when you present your quality indicator, what do we do is we normally say there is nil fall in the last 3 months. But why don't we go one step forward? There were 25 near misses that was captured and we acted upon it. And probably that is the reason we did not have a fall. So this will give a very strong scientific foundation for us to move forward. Importance of near miss reporting is why it is important. I need not talk about this because most of you will know. If you want to put in the chat anything beyond this, please add to the chat. It will be interesting for us to also read that. Please add it to the chat. Proactive learning is one thing that comes out of because of near miss. What is this proactive learning? We can proactively prepare ourselves so that we'll be able to curtail or prevent a particular activity, or it gives a systematic improvement and a patient safety focus. So these are the three aspects that will help us if we are focusing on the near misses. Now when you see a near miss today, could be an accident tomorrow. Yes, you all will believe in that. So today's near miss, yes, tomorrow's a near miss. Maybe 10 days it is a near miss. Maybe the 11th day it appears as an accident. So reporting near miss actually prevents a patient X from getting injured, and the employees, whoever is involving, they get better. This is one type of upskilling, I would say. I think Tangam will accept when I say this upskilling. So upskilling components comes with near miss proactive planning. If you say there are 10 near misses that has happened, then that is the focus that you have to have for CNE for that particular week or even particular day. So you could do a cross-sectional assessment of this, or even if it is not self-reported, you can encourage self-reporting, motivate people to report. Probably you can award more self-misreported units can be awarded, so that what happens is the team come forward and they are able to be always watchful. One thing is you're making the healthcare professionals more vigilant because they have opened up their senses to watch near misses. It is not that easy to observe near misses and to report. It needs extra special attention, a deliberate understanding of what is happening around. Just mechanical way of doing nursing or doing medicine, medical work, or paramedical work will never lead us to capturing near miss. So there are multiple angles that you can give to this near miss capturing, and that comes only with, I could say, cognitive, the attitudinal part, and also it gives a kind of a boost and a morale for people when they are rewarded. So when the reward comes, what happens? Automatically the nurturing happens. So reward nurtures, nurturing increases near miss capturing, and that will actually promote lot of insights into the organization. Now these insights can be presented in the boardroom, and the chief nursing officer, or maybe you have a chief maybe infection nurse, or somebody who is taking lead on certain pillars or verticals, can come forth in the meeting, and the medication management nurse can present in the pharmacy and therapeutic committee, that these were the near misses that had been captured. Probably a tissue viability nurse would come to present in operation theater meeting, or probably in the critical care meeting, or probably in the nursing council meeting, and she can say that these are some of the incidences that were captured as a near miss. Probably today it's a near miss, and tomorrow it could become an incident, and that will actually cause damage not only to the patient but also to the name and fame of the organization. Now, role of a nurse in identifying near miss. So, what do we do? Frontline observation and intervention is the best thing. So, please include this as one of the induction slide or induction topic. Let the nurses know right from the student period that near miss observations are very, very important, because they play the crucial role. They are in the front, they can observe, and they manage the nurses station. The nurses station management, when you say nurse, NABH nursing excellence have got something called as nurses station management. So there the focus should be on this, and that is how, like, we remember that the nurses have to play and have an opportunity to play a lot in capturing the near misses. It is just not in nursing, it is widely across the spectrum of patient care. And reporting and documenting them is very important. This will happen, I think the leaders have to support. The philosophy of the organization should support. And that is where, like, you have to promote an opportunity, create an opportunity, inform them. See, unless it is informed, why they will not be coming forward to report. So it is important for us to say, in our organization, there is an opportunity for you to bring out a near miss, and you will be considered a special person because you have a detail, an eye to details that you have seen and you have reported. Now, promoting a culture of safety is another very important thing which I have discussed earlier. So, this is the ultimate responsibility of nursing. So, nurses can proudly say that these were the near misses captured by us, and you can even calculate it in cost. Like, I think Abdul also knows, like, we did one project when he was working with me, so we converted that into cost, and we can present that cost. So this is a cost if at all that near miss has resulted in harm. Now, when you present this to the management, you tell management that a portion of it can be given as an incentive or for recognizing the nurses, because they are earning it. They are earning it by their act, and they have protected it to happen. So these are some of the things that will also give an eye opening to top management, your CEOs, your COOs. So they will get a data. They will get a data saying that these many near misses captured by nurses, if it would have resulted in an action of incident or an error or something more than that, like sentinel event, what is the cost of it? The consequence based results can be presented. It need not be, it's not actual. You can give a projected presentation. It will capture the attention of top management. Nursing will be considered special in that hospital, which the leader projects this way and presents to the top management. So I encourage each of you to take this forward, because it's not that difficult. Nurses are smart, so you can do that. Implementing a near miss reporting program. How do we do that? So this program, it's easy. How we can do it is, first of all, you stratify organization data. As I told you, cluster them, run an even distribution, conduct a deep dive, examine final harm distribution, establish multidisciplinary teams, involve. Let it be a nurse led activity, nurse led initiative. But what you will do is, like, you will involve, when it is related to medication management, involve few doctors, involve the pharmacist, involve the clinical pharmacist, you take the lead. Same way for others. Maybe if it is for tissue viability, then you have to involve a plastic surgeon, you have to involve the other stakeholders, and then make it happen. Or if it is happening in your unit, like you're in charge of ER, come on, you can do it as a ER in charge. You take the lead on that. So nobody's going to stop you for doing this, and communicate the finding, utilize improvement tools, and then start improving it. So then what will happen is the organization will propel forward. So with this, I am completing my talk, and thank you very much for patient listening. I wanted to keep this talk a very short and crisp one, so that you will have some thought process going within you, and you will be able to go back and plan something for you in your organization. Because I believe any webinar or any presentation, if it doesn't result in translating into action, then that is just mere hearing, like watching a movie or something. But I think this is not the objective of us presenting to you. So stay alert to stay safe, report near misses to prevent future incidences. And thank you so much for listening. I have completed my presentation. Tankam, are you able to?
Yeah, you can just say start my video.
Yeah, I
You
have
can
done
stop
it.
sharing. You can stop sharing.
Yeah, yeah,
I am not seeing. So, friends,
maybe.
while Dr. Jyoti is sorting out her video, I would like to open the floor for discussion from the participants here. We have senior people here, we have mid-level leaders, then we have younger people. Let's discuss a little bit because we do have time to understand what are our challenges in catching the near misses. Why is it that we are not able to tap into this, you know, the wealth of, power that lies within the near misses? What could be the reason? May I request Madam Abanti to say a few words because you have been an assessor for such a long time, and I am very sure that you'll have something to share.
Um, yeah, Sankam, I was listening intently, and Jyoti has given so many theories, very interesting. And as usual, I was taking notes. Um,
Okay.
I think what see a lot of mainly medication errors and falls. These are the two things nurse related which is happening. Lot of medication errors happen, and today we are capturing it. But what Jyoti has brought out, the mental model, capturing unsafe practices. This is where the young staff nurses, I feel, they don't realize that they say we are busy, or we are alone, or we have too many patients to look after, and they take it casually, like say double checking or involving the patient. These things get missed out. One day the accident happens, and then it's a big thing. So this point has to be taken very seriously by young staffs working at the bedside, that habit, to make it a habit. Yesterday also you have spoken about making habit. That is very important. When we make habits, then the accidents will not occur. It's just like we wake up in the morning to brush our teeth is a habit. So why can't we cross-check medications, involve family members, read out aloud what we are doing? Why can't we make this a habit? Even if we have 6 patients or 8 patients, it doesn't matter. With every patient, if we do it, this habit will bring the safety culture. This is absolutely for the frontline nurses.
I thank you, Dr. Madam Abandhi, that I think a very, very valid point. Some thoughts which are coming to my mind is that uh, I used to tell my team that even for, you know, minor errors. I used to discuss and talk to people. Then sometimes people will comment, "Madam, it's just it's not a major problem. Why are we making fuss about it?" So I used to tell them that if I don't make fuss about this one, I'm sending out a message to my 399 nurses. If I have 400, one person made this mistake. The remaining 399, they're watching. What are we doing? And if we don't address it, I'm not saying that, we need to be punitive or we need to be doing, stricter action. That's another topic altogether. Normalization of unsafe practices. So, what happens? Small unsafe practice, very rightly put by Dr. Jyoti and Madam Abandi, that someday it is going to lead to accident. So, if we don't talk about unsafe practices today, then the youngsters will think it's okay. It's okay to have that kind of a practice. So, what happened if my patient's ID band was not legible? One full day, three, four people gave medication. Why is ma'am making so much fuss about it? That day went away without much problem.
Tankam,
No medication.
1 minute, I'll rejoin. I'll rejoin because
Please,
my it says I have to rejoin.
please, please, please. So this is very important for leaders.
Dwara.
Mandip Kaur, can you keep quiet? Thank you. Um, Jyoti, you need to log out and then come back again. Thank you. Then I think your video will be visible. It is more important to see you. So what are your thoughts about that? That how many times do we tend to get bogged down by more serious things which are seeking our attention, and then we say, okay, this is not a major one, so maybe are we doing the right thing by letting it pass by? And one of the major discussion in WHO patient safety curriculum is called normalization. We make it normal. It's
So I'm
okay.
happy. I'm happy I came in.
Yeah, thank you. Thank you for coming back. So they'll be happy to see you also. So I'm just talking about the leaders. Sometimes we are so bogged down by so many things asking our attention. Then when it's unsafe practice, when we notice, we say, okay, but did not result in any harm today. It's okay. I will address it later. But those are the things which are waiting to convert into a harm to the patient. So I feel that every event which has a potential to harm the patient must be discussed. It is not the person who should be discussed, it should be the situation. The mental model you said, the culture. The culture should be talk about every event, including near miss and unsafe practices. So it's very important that the seriousness, the youngsters should get it from the leaders, from the ward in charges, from everyone around them. They should know. I think it is good to learn about near miss, but it's so important to execute a process which is not intimidating to the frontline staff. And today's generation, ladies and gentlemen, they are a different breed altogether. There are
Exactly.
not many movies or documentaries being created around Gen Z nurses, so we don't know much about them. But anyway, today's date, the Gen Z behaves in a totally different manner. So they have to be handled also very differently. So they need to be inducted into a culture where they know, if I think I'm an unsafe assignment, I should speak up. That's important. We should empower them. Do you agree with that, Jyoti? That it's important that the ball again lands up in the leader's court once again. I can talk to the nurses, frontline, and students. What is their role? What they have to do every day. But if they think that one day I did a shortcut, nobody told me anything, but someone told me, hey, don't do that. But nothing was discussed after that. So I will try that again tomorrow. Nothing happened. Third day, nothing happens. Then it becomes my habit. That is how most of the bad habits are picked up by human beings. So I would like to take your thought on that, Jyoti.
Mm, see, I am a very different leader, I can say, because I always believe the younger ones need a push from up. And as leaders, when you walk the path, they will follow. Of course, see, even for Jesus Christ, you had a two group, right? So you will have a group following you, a group who might not follow. But sometimes what happen, I have seen the rebel nurses become a very strong potential source for improving patient care. That also I have seen. So basically, I don't see any difference in generation in terms of accountability or in terms of their responsibility. Probably something is not given to them as a base, or probably the environment has not given them the opportunity. Because, see, when you see the same nurses, those who are working with us in India, when they go abroad, they are totally different. It is the same nurse. It's just the context within which they are working is different. Probably the nurses don't fit into the organization currently where they are working because it's not promoting what the clarity for them. That's what I would say for this. Another thing, what I would say is like every time we believe that like we have done our best, probably the younger ones are not able to take it what we are doing, but probably they do it differently. That's what, when I started my presentation, I started with the printed records word. We cannot solve anything with solutions of yesterday. We have to keep exploring. And I like that in you because, see, you and some of our leaders in ANI, Association of Nurse Executive, like Usha and even Ajita, and many of them, no, I could see, and the younger leaders, those who have joined here, all of us aspire to be the best role models for the team. Um, we have come out of the barriers saying that we are best and probably the younger ones are not as responsible like us, but many of the other lot of nursing leaders, I think they have to come out of this thought process because world is changing, mind is changing. I don't know, maybe one young nurse will bring in a solution where we can capture near misses just like that. Maybe the nurse can invent something like how can we prevent near misses even, because see, psychology is more important here. We'll give less importance for how many nurses are specialized in psychology in India. We don't utilize them appropriately. Cognitive preparation of a nurse to be a fit nurse, for a, be a safe nurse, is very important. We always believe 10 times I do the same thing, 11th time, like they say, when I was working in the labor room, my seniors used to say, okay, today you feel like this, okay, you know, you feel the mother is shouting, she's delivering, she's struggling, it'll be very big for you to see, but as days goes by, you will become all right, you will get sensitive to it. That sensitive to what we are doing should not happen. We have to be novel every time. That gives us happiness. That's what gave me happiness. I think it would have given you, Avati ma'am, all of us happiness. That novelty is very important. Now, how do we bring that in the younger generation? That is addressing like a $1 million question, but it is not difficult. I think we need more such talks to younger ones. The leaders have to speak to them frequently. See, when we sit as a director of nursing, we don't have much time. How many times we have sat just to talk with them? It's, I know for me, I try to do it, but for me also it's difficult, although I had it as a philosophy. So those who did not even realize it's a philosophy for them, it is much more difficult for them to comprehend. I think it's a, because you told me under the iceberg, I thought I would bring this concept very clear so that all these we are doing to project nursing. Many times nurses say that we are not respected, we are not taken care, we are not, but I never felt like that. Day one I have joined, either in academia or here, I was able to slash down. I was able to present it, whoever it may be, on the table. I'm sure many of you have done it. Continue doing that. All of us have. But without data, without that intelligence, if you're going to speak, nobody's going to listen to us. Data is very important.
Totally agree.
Documenting results is very important. So I think I spoke a lot,
No,
but I
no,
thought it is
I'm
important for us
thinking
to.
that today you talked about the iceberg, the near misses. So I think of the iceberg in nursing leadership. I totally agree with you. If something is not right today, the onus or the ownership is with us.
We
We start from the academics, the 4 years when we hold these young minds captive. Are we not able to talk about what are safe practices? It's like a mantra if you keep on talking. Okay, look, we are going into a profession which has got a lot of potential hazards all around. It's not a safe place. 1 in 300 patients gets harmed, WHO says. So many times in my classes, I say, imagine we put a disclaimer in the hospital saying, hello, 1 in 300 patient will be harmed. We don't mean it, but enter at your own risk. So we would like to see how many of our patients would actually enter. They will think 100 times before they enter the hospital. Nowadays, even for sneezing, they will enter. But if
yes,
they come to know the hidden hazards, and the hazard is very true for us as a patient, for our family as a patient, for our near ones as a patient. We keep forgetting that many a times. Today we are the provider, tomorrow I can be the receiver. If that's very selfish to think, but if you think that way, at least you will get the perspective right. That
exactly.
today I am doing a shortcut or today the leader is not paying attention. I'm very sure the leaders are being pulled in so many different directions. So that is why it is very important today for the leaders to be strategic in thinking.
Tankam, I want to bring a point here. When we say a nurse who's working in the ward, she has pulled in many times, many sites, but we are making her accountable for every medicine to be given, everything. So leaders have to become accountable. They may be pulled in many angles, but the core, that is what I say, no, the core of nursing should never be forgotten. If you stand on the core, then things will not move out. One example I would like to tell before I could complete the next part. See, I'm learning a lot from my grandson. You know, the way his education system, he's in the preschool, 3 year old, like when I give a shake hand to him, he says, Mama, you're not looking into my eyes. When I give a high five, he says, Mama, into my eyes. I cannot talk to him with my phones on. I cannot say thank you. I cannot go without saying thank you if he says sorry or whatever it is. So, this is inculcated in a 3 year old child, the kind of a discipline. And when I say only one chocolate you have to take, even if you force him to take next one, he'll say, no, one is enough, one at a time. And on the way, he'll never open a chocolate packet. Although we buy it, he say we'll go home and have, not on the way. Because his school told on the road, you have to be safe and seen. You have to focus on your walk on the road. I'm not proudly telling all these. What I'm telling is a 3 year old child can have such discipline. I'm sure we can make a lot of difference in our healthcare for
And I
sure.
think you are referring to the culture in which they are being brought up as a nurse. They are 17 years old when they join nursing, and for 3 to 4 years, they are held by the academicians. So I think somewhere the leaders who are in and around them, we are not doing enough to sensitize them or
Exactly.
that they are getting to the kind of responsibility they are taking. Can you imagine when you are 20 years old? They're given the responsibility to decide that I will escalate an abnormal finding or I will keep quiet. And if I keep quiet, the patient will die. It's actually a life and death in that 20-year-old young, adult's hand. It is unlike any other profession.
Uh, Very
So
surprising when I was doing, when I was an assistant dean of clinical affairs. I used to take a session on medical ethics for medical students in Sultan Qaboos University. You will not believe when I asked the students, okay, you have done something wrong, only you know about it. This is during your final exam, but your instructor has not seen, the examiner has not seen. So, will you come out and say this will harm patients? So, I have done it. So, can I modify it? 80% of them said no. When I asked them why, all of them said because we'll fail. We'll
and
fail.
fantastic example because that's what
We'll fail, they said. So that caught my attention. From then on, like I used to more focus on ethics part whenever I deal with team. Yeah. Yes, Tanka.
yeah, I'm seriously thinking about, that how many of us sitting here will go back and make, especially the leaders who will go back and make an earnest effort to see that can I now focus more on near misses and even unsafe practices. The unsafe practices will become near miss, and the near miss will become an event. And that event can harm a patient, or it may not harm today, it will harm somebody else tomorrow, right? So I don't think that our focus on safe practices can ever get distracted because of any reason for that matter. And being a leader today in today's healthcare systems in India is not easy. We totally agree. So we would like, some of the people, participants sitting here to engage in a conversation. This is also one of the reason that why we don't look at new solutions because we don't speak up. But when we are on our own, then we will complain about everything in the world. Why things are not happening right? We start to blame each other. We may blame the academician. Academicians will blame the leaders. But how do we find solutions? Solutions can only happen, you told in the beginning, if we continue to do what we have been doing all these years, don't expect any different results. We have to do something differently. So we have another 6 minutes. Me and Jyoti, we are going to keep quiet and we are going to ask the participants, please unmute and speak your thought process. What do you think that we should be doing? We are not doing these webinars for all of you to come listen and say, okay, great talk and thank you very much. We would like to hear from you. What are you wanting to do? We are there to help you if you need our thoughts to help you to put something into in place. Please go ahead and discuss. I can see a lot of, leaders here. And even the youngsters, if you are there, you can tell what is stopping you from, reporting even unsafe practice and say, I think I'm in a unsafe environment. I can
There are
do
few
this.
questions also there. I could see Hannah was have some
They're only
questions.
saying completely agree.
Ma'am,
Thank you
if
very much.
ma'am, if I can speak, if I can just add over here a point,
Yes,
um,
Jessica.
if yeah, is to promote and foster error reporting culture among the youngsters. So more often it is so that whenever they come reporting an error or when we come to know there is an incident reported, we get so engrossed in doing the RCA cup of it, but we actually forget what has the nurse has undergone. For example, if a RN there's been a patient fall, we don't understand what would be the plight of that RN, the fear that she's going through to just express, okay, my patient had a fall. We get so engrossed into the depth of the incident to make sure. So somewhere we as leaders, I think should, especially when we talk about the Gen Zs, we'll have to foster an environment where they will come up with that fearless to come and express, okay, I have done this mistake. So somewhere we'll have to encourage that atmosphere or that environment and change the culture or the fear which nurses always have had.
So I totally agree with you, Jessica. That takes me many, many years ago. Forget the Gen Z, the era I was born. first patient I gave mouth care. Actually, I was a student. I was a PTA student. In my probation time, I have been trained to do mouth care with soda bicarb, dish, and all that stuff. So when I went for my exposure, because half day we are in the hospital only. So my senior with whom I was attached, she asked me to give mouth care to a patient. The patient was propped up on the bed, and I am giving as per the procedure, step by step. I am giving the mouth care. And I did not know the patient actually stopped breathing. I never noticed. I am very busy giving the mouth care. And his mouth is open. It was open before also. So I am giving. So suddenly the senior comes and she shouts, and I am like, why are you shouting? Then my in charge came running and she just pulled me out. Then she said, call the doctor. Then I started crying. I said, I didn't do anything. I didn't do anything. I didn't do anything. I am only saying I didn't do anything. I didn't do anything. And the senior who is there, she said, you did not notice the patient stopped breathing. It got even worse. I started crying. I'm 17 years old. My in charge told me, go to the linen room, pull a chair, sit there, and don't come out till I come to you. I will never forget that in charge of mine. I sat there and I am crying. And then when she came back, I started crying more. I said, Sister, I didn't do anything. I did not kill the patient. I'm so sorry. Then he said, First, she told me, relax. First, relax. I sent you here because I know that you will cry and you are blaming yourself. So, number one, this patient was terminal. That means the patient was expected to die any moment. I'm sorry that your senior did not brief you when you are giving the procedure, what you are supposed to look, or she should have been there, but we failed you and we are very sorry. So, and she told me one more thing. This concern that you have for your patient, keep it alive. Not when you are 17, even when you are 67, 70, have that concern for your patient. So, when Jessica was mentioning the plight of the young nurse who is involved in an incident, I'm also guilty of sometimes not paying attention to the nurse because I would think, how the hell you did that? Because maybe I didn't do that kind of mistake in my life, so I think somebody else should do that. It took me time to learn that I need to be empathetic towards the nurse, understand what they are going through, and then see what needs to be done. Today now there are a lot of you know information available how to handle. There are many different processes which is set by larger. I'm sure in NHS I like that model very much. I always cite that model. It is the decision tree they have for incident reporting systems. And we really hope that under Annie we will be able to bring out something like that, wanting to do that. So thanks, Jessica, for giving your share. Would
Yeah.
anybody else like
Uh,
Ma'am, adding. Yeah, yeah. Madam Jessica, go ahead. Then I'll speak.
No,
Yeah.
no, I would just like to thank Pankaj ma'am, Cygnia ma'am, and Nurse India because such a thought-provoking session, which we hardly even think and reflect on such points. So it was very good listening to yesterday's session as well as today's session. That where are we lacking on, or where we can improve upon. So thanks for that, ma'am. Thank you.
Thank you, Jessica, and the
to
entire
get
team
yours?
who have joined. Yeah.
Ma'am, kind of resonate with Tankam, ma'am, but in a different way. But to be very frank, probably Tankam, ma'am, had a very good in charge or a team leader who encouraged her to understand the situation and reflect upon, and then kind of take it over and understanding the impact of the error which has been created or whatever happened. But in reality, how many of our nurse leaders are ready to accept these errors when the nurses come and report it? They, instead of accepting it, they actually shout at the nurses. They kind of scream, they react as if the entire world has gone to a doomsday or something, and the next day these nurses are not there in the duty, they abscond themselves. This is a current situation what I am actually facing in my organization, where I'm kind of handling 27 hospitals across India, and cities like kind of remote, where we have in kind of remote areas of Andhra or Gujarat, where my nursing heads are also not having this capacity to accept, probably I wouldn't say it is a mistake, but probably they are also been pushed towards bringing more patients. One error is equivalent to one patient lost for them. The consultants are not happy bringing the next patient. The referring doctor is not referring the patient because some error has happened. So I don't know, as leaders, I'm asking your ideas and suggestions. Like, how could we change this mentality of such nursing leaders? When a situation is making them to be more harsh on the nurses, or probably strict on the nurses because of something else, or some situational forces, external forces which is pushing them.
Okay. That's
Abdul.
so I would like to hear from some more participants. Abdul has put a very valid point.
Another one point is brought out by Sridevi.
Yeah.
Similar point.
Many of the leaders, as they want, is explanation like that.
I say that you're wasting organization paper, you're wasting nurses' time for organization. They'll write the letter. So, in fact, we put a full stop for all explanation letters. Explanation
I
letters
also did the same because it
should
happened in
not.
Fortis. Before the supervisor can go and even get the incident report or ask even, they would have written the incident report, they would have written the explanation and say, this is what you want. They are telling us what we are. They are telling,
Agree,
you
agree,
don't
ma'am.
want to listen to
Yeah,
me, you want the paper. Here is the paper, take it. So
yeah.
that is what the general see, we
We
all
should
keep talking
stop.
in our
Stop.
time. We were so much afraid of our seniors, and we will, if we don't tell, then we will be held responsible. So we will go and tell. And there was a different way they handled us. I used to think they were like tough love. They were tough
We used
with
to
us.
give,
Yes, yes, ma'am.
we used
Yeah.
to give a
And
Brevo card.
they are loving us also. But I think the question that Abdul is asking, that how do we change the mindset of these leaders? Now, from my side, there is no one single answer. Each system, like if you have, Abdul, you have 27 units, and if you have different, in charge, maybe you should have smaller groups where you should try to understand their anxieties. The consultants who is coming and saying that because of you I lost one patient, do they have the maturity how to address that kind of a comment coming from a consultant? Maybe they have never handled something like that.
No, they are not qualified to be a mid-level leaders. It's just by virtue of being there for few years, you're pushing them to be the in charge. They are not given
Exactly.
proper training. They don't even have CNEs properly. But otherwise, what Abdul speaks is the attitude part. That's what I said. No, when you're exposed to certain things, then you become very mechanical. That novelty goes off. You don't see the soft part of people those who are working with
I
us.
think day after tomorrow, the simulation is a very powerful way of actually sensitizing people, where you can see something happening in front of you like a movie and opine about it. So I really hope all of you will come back day after tomorrow to listen to that, and then see that, Abdul, you can find some answers in that. There are no 100% answers for every question that we have in nursing. And
But
Jyoti definitely told one thing is that in nursing, we don't have a way of preparing someone to be a mid-level manager or even a supervisor, even to the level of CNO. We are not prepared. How do we manage the
But you
human?
can write a SOP on this, circulate it, and make this known to everyone, and even the junior nurse who can escalate if suppose she is not come. So make them together, like to listen to the younger ones. How did they feel? So you cannot change the entire world. Probably you can take unit by unit and then you can make it forward. So
I also
that's
think
how like I have tried in my leadership.
I think you may also have to get involved. I mean, that's the only way, because when there is a problem and we have a
Show the way.
difficulty,
Show the way.
go in there and get involved, talk to the consultant, and then see. See, it is always a good idea to co-opt the clinicians into your problem. That's a smart way of doing it because they behave in a certain manner. It is very important to understand their psyche and moderate or modulate your behavior so that they also co-own the thing. Like, for example, when
Very
doctors
true.
shout in public, I will just go and whisper to them. I'll say, sir, when you shout like this, it is not that you are making the nursing look bad. You are making yourself also look bad because your patients will not come here because they'll not trust the system.
You trust this institution.
They want to
Exactly.
trust the system. So don't you think it's nice that we talk about it separate? It worked. It worked with almost all the.
It works.
And I happened to see a doctor with whom I used to have a lot of friction because he used to be like that. Finally, he
Very.
stopped doing it because the nurses told, "Sir, आप हमें डांट लो, हमें नहीं भेजना मैडम के पास." And for me, that was a very good solution. I met him, and then he was asking me what I'm doing and all that stuff. And he just told me one thing, it is sad that you don't work in hospitals because you were good. I said, oh, thank you. Is that a compliment? And when I was working, we always used to rub ourselves, against each other because he had a difficult way of, managing the
But
nurse.
they remember us forever.
So, Abdul, no panacea for all these things, but I think what you can do is get involved and probably show them the way because they are probably not aware behaving like that they are actually pushing the nurses out of the system.
Very true, ma'am.
So,
That's what I'm trying to do every month. My itinerary of traveling out of Bangalore from a base is fixed. Today I'm sitting at a place called Bhavnagar in part of Gujarat. I'm here since 2 days, so I'll be here extending again till Saturday. So it's all about firefighting, but I'm just kind of pushing the nursing leaders also to understand and to get that particular level of maturity is कि पहले चिल्लाओ मत, पहले ये डांटो मत, कि पहले समझो कि सिचुएशन क्या था नर्स का. So that particular understanding is kind of, probably it will take time for them also, as Clara ma'am was also trying to say that we have not put them into a structured way of developing them as a leader, or probably of years of experience we have made them as the team leaders, nursing officers. So yeah, very true.
Even in BSc program, the leadership is there. Like there is a semester for that. We don't have such case scenarios discussed there. I think it should start from there as well.
Exactly,
exactly.
ma'am.
Mm.
Someone talking about
Very
second
simple to
victim.
work.
Yes, you can write down the policy. They should change the attitude of mother-in-law. Yes, famous
Yeah.
mother-in-law, but there are some great mother-in-laws also. And they are better than
Ma'am,
mothers
they can
sometimes.
become the mother-in-law instead of
Ah,
law.
yes, yes.
Yes, Elizabeth.
Upper mid-level induction program and NLP would help. Yes, definitely it will help, but it needs to be current and it should include practical tips how to manage, navigate our systems. In NHS, it's a different system. I was talking to someone who went to Ireland today. By mistake, I thought she's still in Mumbai. I called her and then she said, I'm in Ireland. So I said, how is it? She said, there is a sea difference between the culture in India and in Ireland. She said there is a nurse who can stop the discharge if she wants. So I was asking her, what it will take to make our system like that. So she had a couple of points. One is the culture itself is not empowering to nurses. So it is when it comes to empowerment, I remember the quote from one of the CEOs that I worked with. So he said, Tankam, empowerment is as much as you would like to take it. I think it's a good thing to remember. Empowerment is as much as you would love to take it. Nobody can give it to you. This is something that we earn, right?
Earn.
So I think all of us have to raise our bar and prepare our young nurses to get themselves empowered. I think all these things that we are trying to do is to give everyone some insights into some doables. And I hope after listening to Dr. Jyoti today, you have made some action items in your list, your mental list, or your book somewhere that I'm going to do this differently because I was here. One thing Maybe yesterday you wrote one thing, today you wrote one thing, maybe day after tomorrow you will write one thing. The three things. And then you tell that to three people. That is 3 into 9. And 9 people will tell maybe one more person, 18. That is how the ripple effect will happen. So thank you so much, Dr.
Thank
Jyoti.
you, Tankam. I am putting this as a paper as well. So maybe once it is done, then I'll share it with you.
Also, definitely. It is more important that we should discuss more around this. And technology is there. So one should always lean on technology to make reporting easier. So that is something all of us have to keep our eyes open to see that technology need not be very expensive. It need not be very complicated. You can make it pretty simple also. So I was listening to someone the other day. They said they did away with all papers. Now they're doing a Google form. So that's one simple way of doing things. So if you have a strong IT, assert, ask for solutions. It is very important. You should, because IT people, they can do anything that you ask for, but the idea should come from us. We know the process very well. So, thank you so much, everyone. Thank you, Dr. Jyoti, for sparing the time from
Thank
UK.
you so
Hope
much.
to see you in India soon. And
Yeah.
thank you, everyone, for joining us. And we really look forward to meeting you for our third in the series, day after tomorrow. Very novel, interesting session about simulation for doing root cause analysis, because they are all connected. What we did discuss yesterday, what Dr. Jyoti discussed today, and we are going to a process, to see that is there an innovative way of finding better, solutions for the problems rather than looking at the person, looking at the letter, looking at the explanation letter, and then we'll discuss all that day after tomorrow. See you all day after tomorrow. Thank you so much for being
Thank you.
here. And we will definitely upload all these videos on our, YouTube channel soon. And thanks once again, Jyoti, for being here.
Thank you, Tankam.
See you,
Thank you all.
all
Thank
the
you.
participants here.
Yeah.
Take care, stay safe, and keep our patients safe. Bye bye.
Bye, ma'am.
Bye, ma'am. Thank you.